Revenue integrity and charge capture is our episode topic. My guest is Ashley Tomczak, a former nurse turned revenue cycle professional and senior managing consultant at BRG. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Ashley, thank you so much for joining us today.
Thanks for having me.
So you're a former nurse, you were a practicing nurse, and you've moved over to the revenue cycle side to focus more on finance and hospital operations. Before we get into talking about charge capture and revenue integrity, tell me a little bit about that transition.
Yeah, so I don't know that I have the most traditional transition that most folks might experience, but I kind of knew that I wanted to be involved in patient care from as early on as high school. I was involved in a program called Health Occupation Students of America, and that really just gave me like a love for the difference that compassionate care really can make in a person's life. And so I knew like nursing was it for me. Upon graduation, I found out that my local community college offered an accelerated ASN program, so I enrolled in that, eventually sat for the NCLEX, started working on a med-surg unit, and then was also attending Illinois State full-time, working towards my BSN. And so about 3 years into that program, I decided I really wanted to do something different. I wanted to stay in healthcare in some capacity, but I knew that I needed to shift away from that. So in my 20-something-year-old brain, in an effort to be able to complete my bachelor's still in 4 years, I discovered health information management. And there was a program that offered that opportunity to become a registered health information administrator upon completion. Back in those days, the state was the only school that was offering an accredited program. Now you can find them pretty much anywhere. So I thought this is something pretty special. It covered information governance, compliance, disclosures of protected health information, data analytics and informatics, revenue management, project management, and leadership. So for me, revenue cycle just made sense. It allowed me to put both my clinical and non-clinical background to use simultaneously.
So you got your degree in health information management and you left the bedside. Where'd you go next before going into consulting?
I was actually working in a traditional hospital patient financial services area for several years on the revenue cycle side. And it was that really allowed me to realize the gaps that you can close between the revenue cycle piece and the clinical piece. Kind of what I mean by that is there was always a time where nurses focused on patient care and revenue people focused on revenue. But I think in the last several years, there's been this paradigm shift that now revenue is everybody's business. And unfortunately, a lot of that burden has been shifted to nurses in the clinical areas.
Knowing what you know now about revenue and charge capture, what would you possibly have done different in your practice as a staff nurse years ago?
I think I would have been more curious about the impact that your clinical documentation has on the organization as a whole, not just from a patient safety aspect, but really from a compliance, and a revenue driving aspect.
We had Laura Jacquin on an earlier episode to talk about all things CDI. Your area of specialty is more on revenue integrity and charge capture. What are the key components in a hospital that most hospitals are missing when it comes to charge capture?
So revenue integrity really helps organizations bridge that gap between the clinical area and the revenue cycle. So to answer your question a little more directly, a large part of that is improving your missed documentation opportunity, especially where that revenue is impacted. That's really become particularly important in this post-pandemic environment, where one of our biggest challenges is generating revenue on thin operating margins. It's not uncommon for poor charge capture to be the driving force of lost revenue. It's really important to acknowledge that at the very core, charge capture is the process of getting paid for the services being rendered, getting paid for the work that you do and the services that you provide to your patients every single day. And I think when you frame it that way, it shines a light on just how vital that is, especially because without appropriate charge capture, you're not getting paid in full, and that revenue is oftentimes not recoverable.
What are some of the key things that you look at when you go into an organization around charge capture? Where are key focus areas that I should look at if I'm a nurse executive right now and am concerned that maybe I could do more to help the margin of the organization?
HFMA, or Healthcare Financial Management Association, actually has reported several times that it's breakdowns in charge capture that present a significant obstacle. Oftentimes, it's as much as 1% of net charges are lost due to the charge integrity leakage. So the areas that I tend to focus on really are those high volume outpatient areas. So think about the emergency department, observation services, radiology, cath lab and specials, OR, pharmacy, things like that. And really the importance here is that patients are always the priority. And that makes it really easy for providers to forget key pieces of documentation.
So let's talk specifically about the emergency department for a moment. Is it the visit level charge that's the issue? Is it procedural charges, IV infusions? Where should someone focus as an opportunity to improve revenue? And how do you know when there's a problem in the ED related to charge capture?
All of the above. So it starts on your visit level and making sure that you're documenting all of the things that you're doing. And that really helps determine what your visit level is going to be. And it's important to note in a lot of conversations that I have with nurses in the emergency department, in the coding world, we talk about visit level 1 through 5 on your distribution scale. To nurses, to emergency department nurses, that's something completely different when you're thinking about your ESI levels, right? So in that world, 1 is the highest and 5 is the lowest, right? Where in the coding world, it's exactly opposite, 1 to 5. So it's really important in order to capture the true acuity of your patient, that we're documenting all of our assessments, all of our interventions. Whoever is assigning the visit level, be it your system or somebody manually on the back end, that they're able to appropriately assign that level to account for those services that you're providing and making sure that we're capturing that acuity. So when it comes to procedure capture, particularly in the ED, it's not uncommon to see a nurse document something along the lines of suture by physician. They may not even know or be aware of that in order to qualify for reimbursement, you need more information, such as the location and the depth and the size of that laceration. So right there, that would be another opportunity to capture additional revenue.
Okay, but to play the devil's advocate for a moment, can't you just pull that off the procedure note that the physician or provider should be entering in with the care that's being provided?
You can, but it's not always captured on that side. So I think it's really important to make sure that we're capturing that from a nursing perspective.
Okay. When you find problems in an emergency department, does it tend to be like a consistent theme within that particular organization? Is there a consistent theme nationally? Or does it, when there's a problem, it tends to be all over the place for that particular department, and there's a lot of education that's needed?
I would say it's a mixed bag. But generally, one issue, believe it or not, that we see so commonly still is more related to injections and infusions and the appropriate instrumentation around those. One thing that I think nurses aren't acutely aware of is the time component required to actually charge for the administration of an antibiotic, or whether it's a hydration agent, or if it's a push med. There's a lot of different rules and that are all time-based that really determine how you charge that administration. And they all carry different reimbursement rates.
Haven't a lot of the electronic health records fixed this problem around charging with how the orders are placed within the computerized physician order entry? That, for example, if you're given an antibiotic that's going to infuse, that the order itself says fluoxetine, 500 milligrams IV over 60 minutes. Is the infusion times not even listed in the order itself?
You would think so, wouldn't you? The problem is that CMS actually has stated repeatedly that an order stating an infusion time does not count towards your administration code that you can assign. The nurse must actually document the time that the infusion started and the time that the infusion stopped, regardless of what's on the order.
So clearly there seems to be some EHRs that maybe are doing this better than the others in terms of an ability and ease to capture, particularly the stop time, right? Because the start time is always going to be there.
I don't know that it's so much the EHR as it is more organizations are moving towards smart hubs. But then the challenge there is integrating that with your EHR and making sure that's getting documented appropriately.
And so if you don't have that time infusion that's listed there because you don't know how long it took to infuse, what happens?
You're leaving revenue on the table. You're either downcoding from an infusion to a push, which is reimbursed at a lower rate. But in the case of hydration, you're leaving revenue on the table completely.
Are IV infusions an issue also throughout the hospital, or is it just an issue in the ED?
It really tends to be an issue throughout the hospital. So some key areas to note would be, outside of your ED, would be your infusion centers and observation areas. And to some degree, labor and delivery if you've got observation patients in that area as well.
Okay. And so let's assume that you're working with a client and you've identified that there's an issue related to infusion capture times and the impact of revenue that it's having. How much loss can you recoup from a performance improvement initiative around that? What do you typically see when you focus time and energy around it?
Of course, it's going to depend on the size of the organization and the contracts that you have in place. But on a typical engagement, we can see anywhere from $500,000 to $1 million of net revenue improvement on an annual basis.
And how does the frontline staff react to the education that they receive and the structures that you put in place to improve revenue capture?
I would say a lot of times you're first met with a little bit of resistance. And it's really more related to exactly how you posed it in the beginning, Nick, when you asked about orders. And isn't having an order saying that this is to infuse over X amount of time, isn't that good enough? But I think once you're able to really explain and provide that education to the frontline staff, they start to understand that, okay, this really is an important piece of documentation that I really need to get in the habit of adding to my daily routine. People are much more on board with it once you frame it that way and they start to really understand the why behind it, rather than it just being, air quotes, another task or another piece of documentation that they're burdened with. As we know, it's a lot. There's a lot of documentation requirements being placed on nurses.
Is there a key metric that you look at around IV infusion capture? I'm an executive and I want to quickly know, hey, I've got a problem. I need to focus on this, or everything's okay. We're in the ballpark or the sweet spot of where we need to be. What's that key performance metric that could tell me, or is there one?
Well, now you're giving away my secret sauce. We have proprietary tools and dashboards in place around those metrics And it's mainly focused around volumes in each particular area and acuity of the patient.
Okay, so it quickly will help you garner, hey, there's an issue we need to focus in on. And that dashboard helps the executive trend the improvement or lack thereof.
Absolutely.
Okay, so what else?
I think is another really good example that's coming up more and more lately, particularly around NDC mismatches. And that is really where your charge master and all of the behind the scenes revenue drivers become really important. And opening up those lines of communication between the pharmacy and your revenue integrity teams within your organization. There's constant NDC changes as new drugs come to market or formulas are changed, drugs are revised, things like that. And so we need to make sure that we're keeping the charge master on both the pharmacy side and the hospital side in sync with each other so that we are really charging and getting reimbursed for the services and the drugs that we're providing.
I'm a little bit surprised by that. I hear you alluding to the fact that there are some organizations that are out there that don't keep those two things aligned. And the result of that is a significant loss in revenue. Is that an accurate assumption?
Yes, that's an accurate statement. Yes.
And so what happens in those scenarios, Ashley, because some of the drugs are really expensive?
Yeah, you can catch that pretty quickly if you've got a good pulse on your denials. You will start seeing those specific denials start to skyrocket. And that's when you realize that we need to take a step back, probably put together a task force, make sure that we are in constant communication with the pharmacy team. We have processes in place to keep those updates flowing through the system, things of that nature.
And so while the charge capture around infusions and visit levels is really more at the bedside and the frontline nurse, so to speak, of their behavior that needs to change to improve revenue, the NDC issue in pharmacy that you're talking about is almost entirely behind the scenes in terms of how the databases are built together and matching one another. Is that an accurate understanding?
Yeah, that's exactly correct. So I think that just outlines how much complexity there really is to keep everything moving in sync with each other and making sure that your reimbursement continues to be accurate.
One of the other things that you mentioned earlier is the term denials. And I'm wondering, is as a nurse, if I tend to over document my assessments and over document, whether it's from a perceived need to defensively chart or I'm an overly thorough professional, I guess I'm wondering, does over documentation in any way result in potential upcoding or upbilling that may cause denial issues downstream?
As long as your documentation is an accurate depiction of the services that you're providing, I would never recommend that anybody shy away from over documentation. The more that you can drive home that point, I think is really appreciated by the coders so that they're able to really gain a good understanding of what it is that you're doing, it is that they should be coding for.
All right, so we've talked about pharmacy, we've talked about procedural areas and infusions. Where are other areas of missed charge capture?
In your OR, there's typically some opportunity, again, with it just being such a high volume area with very complicated things going on. And then there's a combination of, like I mentioned, your charge master. There's hard-coded and soft-coded items. Hard-coded means that the CPT or the procedure code is attached to a charge. Soft-coded being that the coder has to append that charge code, that CPT, that procedure code to the procedure. So in the OR, poor documentation can become more complicated with the combination of hard and soft-coded items. For example, an item is hard-coded when that charge master automatically assigns a procedure code to a service. And an item is soft coded when a team member coder actually has to manually assign a code to the service. Unclear documentation in that instance really can lead to confusion in that operating room, specifically around deciding what is being performed and what we actually should be charging for. Also in the OR, there should be a heavy focus around your devices. You want to make sure that your implant has the correct identification code. For example, a clinician maybe charges a dual chamber pacemaker when the implant log lists the item as an automatic implantable cardioverter or a defibrillator pacemaker. And that would result in some lost revenue in that instance.
Okay. I'm just wondering at a more systemic level, and we talked earlier about denials, is there some organizational structure that is a leading practice to monitor threats to charge capture and threats to revenue integrity so that real-time or near real-time corrective actions can be put in place?
Yeah, I think there's a lot of criteria for effective charge capture. One of those being that strong and versatile reporting. Another being trending, just like you alluded to, charge accuracy and customization, making sure that your interfaces are simplified and user-friendly. Also, focus on charge reconciliation. Did we take into accounting of all of your patients from the previous day, and did we accurately capture all of our charges, be it procedure, drugs, supplies for each patient that we interacted with? I think, another important thing is reporting transparency, having that open line of communication back and forth with those departments and having the departments know that your revenue integrity team is there to support you and to help you understand accurate charge practices and ways to improve your charge capture. And then also keeping an eye on scalability. So can your charge capture process grow and adapt and evolve as your organization does?
This has been a lot of information to digest. Any closing thoughts or things that we need to talk about that we haven't covered yet?
I think really just making sure that we're stepping out of our silos, both from a nursing perspective and a revenue cycle perspective and a revenue integrity perspective. I think it's really important that those three areas really integrate and work together to make sure that we have full transparency, regular reporting, frequent communication, regular check-ins, things of that nature. It's important to have your chief nursing officer within any organization having a seat at that table to have those discussions around revenue capture and ways to improve your net revenue related to the services that you're providing. Really, it's all about building a partnership around shared goals.
Excellent. Thank you so much, Ashley. I appreciate you taking the time today to sit down with us and talk about revenue integrity and charge capture.
Yeah, thanks for having me. It's great.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.